and the first lecture entitled Diagnostic Performance of MRI in Assessment of Anterior Knee Pain in Young Athletes by Dr. Reem ALY BASTAWI. Okay.
Good morning, dear professors and dear colleagues. It's my pleasure to participate today by presenting my work about the diagnostic performance of MRI in assessment of anterior knee pain in young athletes. Anterior knee pain is one of the most common knee complaints usually occurring in adolescents and young adults. It's more common in athletic individuals and comprises up to a quarter of all knee problems treated at sports injury clinics. It can manifest as insidious onset of symptoms during activities associated with patellar loading, such as squatting, climbing activities, and running. The anatomy and pathologic conditions of the anterior knee can be approached systematically by organizing the region into 4 layers. The superficial layer of fat, fascia, and bursae, functional layer composed of the extensor mechanism and the patellar stabilizers, intracapsular extrasynovial layer containing the fat pads, and intra-articular layer. Symptoms in the anterior knee may be due to conditions affecting one or more of these interrelated layers. The aim of this work was to review the most common causes of anterior knee pain in young athletes and highlight their MRI imaging findings to allow more accurate diagnostic performance and improve treatment of this common complaint. This study was conducted on 80 athletes ranging in ages from 10 to 35 years who presented by chronic anterior knee pain with no preceding history of direct trauma and were referred to the Radiology Department of Alexandria University Hospitals after orthopedic consultation. All examinations were done using 1.5 Tesla machines using routine MRI sequence, including sagittal T1, T2, and proton density sequences with or without fat suppression, as well as coronal fat suppressed proton density sequence. This table demonstrates the distribution of the studied patients according to the final diagnosis. Patellar tendon disorders were the dominating abnormality, accounting for 45% of patients, followed by the fat pad impingement. Patellar tendon disorders included in the study included Osgood-Schlatter disease as the most common abnormality, identified in 21 patients, followed by jumper's knee, patellar tendinitis, and Siding-Larsen-Johansson disease. Osgood-Schlatter disease was diagnosed by presence of bone marrow edema at the tibial tuberosity involving the attachment site of the patellar tendon with or without associated insertional patellar tendinitis. Fragmentation was identified in older age group included in this study. Jumper's knee was diagnosed by the presence of focal edema and proximal patellar tendinitis with or without partial tear, which was identified by presence of partial disruption of the innermost fibers of the proximal part of the patellar tendon. Siding-Larsen-Johansson syndrome was diagnosed when we found bone marrow edema at the inferior pole of the patella, identified in the sagittal fat suppressed and sagittal T1 weighted sequences with or without associated proximal patellar tendinitis. The fat pad impingement syndromes included in our study were the Hoffa's fat pad impingement as the most common one, followed by the quadriceps fat pad impingement. The quadriceps fat pad impingement was diagnosed by the presence of bone marrow edema, nicely demonstrated at the mid-sagittal fat suppressed proton density or T2 fat suppression, identified at the quadriceps fat suprapatellar quadriceps fat pad, and the sagittal T1 weighted images demonstrated the replacement of the normal fatty signal of this area. The coronal fat suppressed sequences also nicely demonstrated the presence of edema at the quadriceps fat pad. The Hoffa's fat pad impingement was diagnosed by the presence of soft tissue edema at this characteristic location of superior lateral part of Hoffa's fat pad, which was also nicely demonstrated in axial and coronal sequences. Symptomatic bipartite patella was identified in 5% of patients. Bipartite patella per se is normal anatomic variant, which is asymptomatic, but when there is some sort of instability at the synchondrosis between the bipartite bone and the patella, this results in presence of symptoms, and the MRI nicely demonstrates the bone marrow edema at the bipartite patella with or without abnormal hyperintensity at the intervening synchondrosis between the bipartite bone and the patella. The prepatellar bursitis was diagnosed by presence of distended prepatellar bursa with second synovial lining. The coexistence of more than one entity related to anterior knee pain was found in 6 patients. Hafez fat pad impingement was the common pathology among these patients. The combination of Hafez fat pad impingement and jumper's knee was identified in 3 patients. The mid-sagittal fat suppression proton density sequence demonstrated the jumper's knee with proximal patellar tendinitis and associated small partial tear, and more lateral sagittal sequences demonstrated well the characteristic Hafez fat pad impingement at its characteristic location of superior lateral part of Hafez fat pad. The combination of Hafez fat pad impingement and Osgood-Schlatter disease was identified in 2 patients with its characteristic fragmentation of the tibial tuberosity and associated deep infrapatellar bursitis in this patient, and again the more lateral sagittal images demonstrated the characteristic Hafez fat pad impingement in its typical location. The combination of Hafez fat pad impingement and chondromalacia patelli was identified in 1 patient with focal chondral defect at the retropatellar cartilage and the mild edema at the superior lateral part of Hafez fat pad, which was also nicely demonstrated in the coronal sequence, and the axial T2 sequence nicely demonstrate the focal chondral abnormality. So to conclude, MRI is fast, safe, and non-invasive imaging technique which has been proven to be the modality of choice for establishing an accurate diagnosis of different knee pathologies that cause anterior knee pain in young athletes. Familiarity with diseases of the anterior knee is important in understanding the source of symptoms, which is necessary to decide appropriate treatment. Thank you.
Thank you, Dr. Alim. Any question from the audience? Okay, Dr. Alim, I'd like to ask you a single question. Is about if I find normal MRI of the knee and the patient is already complaining, do you suggest any further investigation?
If the patient is complaining and MRI of the knee, I think it's the final imaging modality that we can demonstrate that there is an organic pathology. I mean, if the MRI is normal and we are sure that the chondral abnormality, that there is no chondral abnormalities, I have to exclude subtle abnormalities, which like minor osteochondral injuries or minor chondral injuries, minor meniscal tears. If this was totally excluded, so it's MRI normal.
Okay, what about MR arthrogram? There is a rule in chondral injury?
For chondral injury?
Yes.
Without any abnormality, I didn't meet.
Maybe beneficial in some subtle chondral injury. MR arthrogram is beneficial, or CT arthrogram. Okay.
Okay.
Okay. Thank you, Doctor.
Thank you, Doctor.
Next speaker.